I would like to welcome all of you and thank you very much for taking the time to participate in this webinar, which I hope will be interesting for anyone who follows in these conference-less times. Most of the areas we will cover stem directly out of published work of our guests during the recent years, with a spin towards continuous objective measurement and more so towards PD Monitor. PD Monitor is a CE-marked Class 2A medical device brought to market by PD Neurotechnology. Sometimes I may use quotes from your publications in order to stimulate discussion. I am sure that the participants in this webinar will be as excited as we are about these topics. And without further ado, I would like to introduce you to our guests in alphabetical order. So we have Angelo Antonini, Professor of Neurology and Head of Parkinson and Movement Disorders Unit at the University of Padua in Italy.
Hello, everyone.
Hello, Angelo. Thank you for being here. Per Odin, a Professor of Neurology at the Lund University, Sweden, and the Head of the Department of Neurology at the Central Hospital in Bremerhaven in Germany.
Not anymore. Not anymore. You to skip Bremerhaven.
No. Sorry, Per. So
only Lund.
Just Lund, therefore.
That's right.
And Heinz Reichmann, Professor and Chairman, Department of Neurology, and Dean of Carl Gustav Karus Faculty of Medicine at the Technical University of Dresden in Germany.
Hello, everyone. Hello, Spiro.
And myself, Spiros Konitsiotis, Professor of Neurology at the University of Ioannina Medical School in Greece and Medical Director of PD Neurotechnology. At this point, I would like to disclose that our three guests have served in PD Neurotechnology's Medical Advisory Board. So, Angelo, Per, and Heinz, it is a true honor to have you with us today, and thank you so much for your participation. Advanced treatments, and we mean continuous levodopa infusion in the duodenum or deep brain stimulation, usually of the subthalamic nucleus, or subcutaneous apomorphine injection with a pump. Those are among the most important breakthroughs in the treatment of Parkinson's disease, each one with its own indications. And while there is an overall scientific discussion as to potential adoption by patients in earlier stages of the disease. In any case, in this last part of the webinar, we will discuss how continuous objective monitoring, and specifically PD Monitor, could help stratify patients for advanced treatments and impact their fine-tuning and the resulting clinical outcomes. So let's start with the health system and in different countries, and given the unmet need for more patients to have access to advanced treatments, do you think that PD Monitor can serve as a tool for patient stratification, patient selection for advanced treatments? And I think this is also related to the validation process for invasive treatments. Do you think that for reimbursement, HMOs, insurance companies, potentially will start asking for some kind of objective documentation before granting approval of a very expensive invasive treatment? So perhaps let's start with you, Angelo.
Yeah, I think this is a very good point, and I think that the number of options is actually increasing as we will possibly have subcutaneous levodopa, for instance, and other forms of continuous delivery or a closed loop deep brain stimulation. So how are we going to select which one is the best for a specific patient? In fact, I think there is a lot of confusion at the moment, and sooner or later, the medical authorities or insurance companies will require the doctors provide some specifics, because otherwise there is too much heterogeneity. And this is, I know that Per tried for many years to do a study to compare infusion versus DBS, and this never succeeded because it was never funded. We tried also with European Union, but it is difficult. But indeed, there are only indirect comparative data to support so. So we will definitely need some objective measures at some point, because and also I think it will come also from the patient perspective, because the patient will ask, why are you proposing me this system instead of another, and why do you think it's a good time to do it? Because and then demonstrating this not only based on doctor experience, which is important, but also on some objective measure, I think it will become more and more important.
Right. Per, what is your opinion? And by the way, if this really happens, what would you expect the validation process to be for invasive treatments?
Well, I agree with Angelo that this is probably another of the main indications for objective monitoring. It is, we all know that there is an underuse of advanced therapies, and one reason for that is that doctors have difficulties to seeing when it's time for this. And also the patients have difficulties reporting what their problems are, and it's a very good feeling to have objective measurement showing that the patient has motor fluctuations, and motor fluctuations that can be treated effectively, or tremor, to have that basis when you make the decision, shall the patient have advanced therapy, and also in the choice between advanced therapies. And so I think that this is already used in many places, like in our hospital. In the when we prepare patients for advanced therapy, we always make objective monitoring, and it would be even more used in that way in the future, because it gives you a much more stable base for the decision about advanced therapy and which advanced therapy.
Right.
And also, of course, the follow-up, once you have started the advanced therapy, to see that it is effective. It is not always effective, and if it's not effective, it can be worthwhile to think about stopping it or changing therapy, and there the monitoring can help you. And also in fine-tuning, of course, the advanced therapy to get the optimal effect of it. We have the experience, for example, with the pump therapies, that often they are used in too low dose, and the patients have off periods that are not really necessary. You will immediately see that if you do the objective monitoring, and then you can use the full capacity of the advanced therapy.
Right, right. Heinz, any comment? And by the way, since Per mentioned it, which symptom quantification would be more relevant, you think, for this kind of documentation?
Well, I think it would make a difference whether a patient has a lot of tremor. That would lead me towards deep brain stimulation, lots of on-off, horrible dyskinesia, again, deep brain stimulation, a lot of off periods, maybe more the pumps. So I would say to differentiate between the three advanced therapies, it may be quite useful beside other things. You will certainly not forget to ask about dementia, cognition, etc. And what you also indicated was money. Most centers in Germany, for instance, they get a certain number of deep brain stimulation procedures per year. And if there's one more patient, you are not happy if the patient has to wait for the next year. So maybe with an objective measurement and demonstration to the insurance company that this patient is really in deep trouble, you may convince them to pay extra. And so I think this would certainly be a tool that we would like to use to do more of this intensified treatment.
Right. You're absolutely right. Actually, I'm allowed to do only 12 per year, for example, which sometimes is a big problem. Now, I think Per gave me a hint to discuss about, and let's make an introduction for our audience. Apparently, there are numerous advanced Parkinson's patients likely eligible for advanced treatments without actually being offered the advanced treatments. So, again, a question to all of you: what do you think is the reason behind this underrepresentation of advanced therapies in the overall treatment mix of advanced patients. And again, can continuous measurement help, given the ease of quantification of the results, or possibly can make things easier for less experienced neurologists, that they don't feel very safe to make this decision by themselves?
Pat, you want to start, or I can start? I mean, I think that I think one issue is always that when you deal with advanced therapies, at least in my experience, is that either the patient is already motivated because they read it somewhere, they saw another of your patients, or they need some time to think about it. And then, you know, there is always a bit of debate what to do, and shall we do this or not, which one is best, if you can offer multiple options. This is, of course, not so good in terms of reimbursement, because if you have a very large demand, very likely they will give you the opportunity to do more cases. Right. So I think, you know, providing some objective assessment becomes very important, both in obtaining reimbursement, maybe for extra cases if you need, because you cannot predict how many patients you can have. It's not a fixed number, maybe fixed minimum number, but the maximum you don't know. It depends on the condition of your patients, and also in showing the patients what is the state of their clinical manifestation, and showing them how it could be after an intervention.
Right. Very interesting. So, Per?
Yes, and I think another component is that we have learned now from several studies that probably it's not good to wait too long with advanced therapy, that to try to come in at a relatively early phase of the complication phase, when off fluctuations have just started and maybe some dyskinesias, and we have several studies indicating that if you treat patients before they are too far into the complication phase, you seem to get a better effect, and this effect seems to be stable, also often over quite long time. So I think that objective monitoring can help us here to detect the complication phase at an earlier stage of development.
Right. Heinz, your comment?
Well, I may add that unfortunately we do have colleagues who think PD is, as we all know, a neurodegenerative disorder, and there comes time when you cannot improve the condition anymore. Also, these are old people. Why should we do all this fancy stuff? This is unfortunately true for some of the neurologists, and also of some of the patients who say, I have a devastating disease and I have to accept to be in deep trouble. And also what we also have to admit, although we do so much education, that this treatment is a little bit more demanding than dealing with a de novo patient. So it is less rewarding, it takes more effort, it takes more knowledge, and that is why some of the colleagues may be a little bit reluctant to take care of such patients, but the least they could do is to send them to centers that are quite willing and capable to deal with these patients. So I think here is still some space for improvement.
Right, absolutely right. So from continuing what we discussed in part B, we can see now objective measurement as a continuum. First, it will be a nice way to know exactly the point when motor complications first develop, and this could be very helpful, I guess, for less experienced neurologists, or for those countries that patients are seen by PD nurses, although sometimes PD nurses are better than non-experienced neurologists. And then the system again will suggest, after a time, the eligibility of patients for advanced treatments, and then if the advanced treatment is offered, will monitor the efficacy of advanced treatment. So does this make sense? It is a continuum where there is a place for objective measurement throughout the course of the disease and the life of the patient with Parkinson's disease. So I guess this is a comment. Now, let's move to the next question. Again, in terms of symptom recognizing, PD monitor can recognize practically every motor symptom except rigidity, of course. So which symptom do you think would be most useful in advanced disease? And how important is to be able to monitor all of them bilaterally and with high accuracy? If anyone feels that one specific symptom in advanced patients would be more important, let's discuss about this, if you think. Would it be tremor, freezing of gait, fluctuations, overall level of activity, dyskinesia? Do you think something is more interesting or?
I think they are all very important,
yes.
And probably it's individual which symptom that has the biggest impact on the quality of life of the patient. So I think it's important to monitor all of those mentioned.
I agree. I would say what my patients tell me, dyskinesia that was mentioned by Angelo also, is not so bad. It's better than to be completely off. So maybe a complete off state would be very important, and also the postural instability, because when the falls come in, there is trouble, the cognition will decrease, etc. So maybe these two symptoms are extremely helpful with respect to treatment and also prognosis. But I agree with Per, it is great to have information on all of these symptoms.
And also in terms of duration. You know, Angelo, more and more I realize how dependent we are on making our patients' lives better by the minute. I mean, we are measuring the efficacy of various treatments by saying this reduces off time by 2 hours or reduces levodopa-induced dyskinesia by 3 hours. We are talking about in terms of hours and minutes. So do you think this is of any help that now we have also a detailed measurement of the duration of the problem throughout the day?
Well, in my opinion, yes. I think there's definitely an important factor, particularly if you have to choose something which is invasive, like deep brain stimulation. I think you need to irreversible. I think still it will be very important to have a good baseline, because you know you're not going to get to that condition anymore. You know, after DBS, things change. After an infusion, you can always stop it, and things will be pretty much the same. But with DBS, is different.
Right. So perhaps this is now the time to focus on DBS, and let's talk about you all spent a lot of time trying to fine-tune the stimulator. So do you think that objective measurement has a place in the process of fine-tuning of the stimulator during the first days of fine-tuning? And during this procedure, which symptoms do you look out for, and how imagine this process to work with PD monitor? Let's start with you, Angelo. Well,
this is really something really time-consuming. This aspect that takes a lot of my time, and it is also difficult to teach to junior people, because it requires a lot of experience. So when you start teaching, then it takes even more time. But that's bad, because then only few people learn how to manage with the different systems, 3 different or more now computers, multiple stimulation paradigms. Right. So there is no standard in DBS, and that is a major problem. Unlike cardiology, in neurology, we haven't been able with this brain pacemakers to find a common standard. That we have been weak, I think, in driving the market. Instead of cardiologists that have been much stronger in convincing, and the authorities also have convinced the company to have common standards. Here, it is very complicated. So an additional complication is really to find the proper stimulation paradigm, how to reduce drugs, how to increase them. This is not only at the beginning. I think when the first, well, actually the beginning is maybe the least of the problem. I think it is more when the patient goes home after 3-4 weeks, then they start losing the acute effect, and then you need to increase the dose. You don't know if it's sufficient. So I think it is integrating a system which can combine both the adjustment and the monitoring becomes really mandatory. I think it would be very, very helpful to have it because you never know when you need, if it is appropriate to increase the stimulation or it is best to increase the dose of levodopa or medications, or the opposite if in case of adverse events. So I think this is really an unmet need, and I wish there will be something more objective to support this work.
Right. So thank you. Heinz, do you also agree with this, or how do you imagine this process to work? Would it be more useful in the acute initial programming stage or later at home when you also have to deal with the dopaminergic medication changes?
Well, I think you need it for both. In our country, we have 2 weeks after the deep brain stimulation procedure is done to adjust the stimulators. And this is a short period of time. Whatever you do, going very often to the patient as a physician or having a PD nurse is certainly not as good as having a device that continuously measures all these features that we have discussed already. And so I would guess that this tool is extremely helpful to find the right way and the right stimulation, maybe a little bit faster and more sufficiently and objectively than if we do it our old-fashioned way. But that does not mean that everybody will leave the hospital in perfect condition. Very often, of course, we need the patient to come back. And so also in this phase of the treatment period, it would be very, very helpful to have such an objective measurement. So I would not say you need it in the early phase after stimulation or you need it in the late stage. You may need it very often.
Right, right. Per, as Angelo said, there is no consensus on the best way. There's no paradigm for setting the stimulator. Do you think we could create this stimulation paradigm with objective measuring devices now to change the paradigm shift as well in how we manage the DBS?
Yes, I think the availability of objective monitoring increases the possibility to establish such paradigms, I think. And coming back to this with outpatient and inpatient, I think some countries have mainly outpatient activities around the advanced therapies, like in Sweden, and in Germany, for example, more inpatient activities around dosing. And so I think especially in the outpatient unit, this type of monitoring is very good, but also in the inpatient, in the hospital, we often have the feeling that when the patient is in the hospital, we know what happens with the patient. But I think both for the advanced therapies and for more basic therapy, it's very valuable to have objective monitoring also in the hospital when the patient is there. And that concerns also when you work with DBS and with the pumps.
Right. And by the way, can you imagine a closed loop between DBS programmer and PD manager, for example? Mm-hmm. Or this is too ambitious to think about it now?
That is not my specialty, really. It's more technical question. I guess that it would be possible in a longer perspective, also with the pump treatments, that one could connect them to each other and get help with the dosing and so on.
Okay. Right. So if anyone wants to comment on this, perhaps we should move to the next advanced treatment, which is duodopa. But before that, I would say, would anyone be interested to to know about axial problems such as freezing of gait, postural instability, gait disorder before moving into a specific advanced treatment, like DBS, for example? I think would be nice to know if our patients...
Yeah, I can comment on this. I think, yes, because it is linked with the levodopa gel infusion, I think, yes, you are right. I think if you have a patient who has, axial problems, possibly this patient may not be best suited for the brain stimulation. And the levodopa carbidopa intestinal gel is definitely maybe a better option for this kind of patients.
Right.
In the case of LCAG, I can only say that the need is most stringent at the beginning, to find the proper infusion dose range and to set that. Because with infusion, generally you need to titrate it the first few days or week. And the BS is probably a more longer shot because you need to give time to the system, to the brain to adapt the stimulation. So for infusions, definitely I think would be very important to have it, and this I agree with Per, for the infusion, particularly in the hospital, because also in the hospital we don't have nurses staying 24 hours with the patient, but we used it actually here in hospital to look at what happened before and after starting an infusion therapy. I think it is and optimizing the treatment, because you can define the gold standard. What is the gold standard, the best condition based on the baseline evaluation sometimes.
Right. Thank you, Angelo. Heinz, any comments on duodopa treatment and PD monitor?
Well, I think Angelo said everything related to that. We are also very impressed if we can monitor good improvement with the PD technology. No, I don't have to add any specific issues here.
Okay, let's conclude this with the third of those, let's call it advanced treatments. But I will not use the case of apomorphine infusion, but rather apomorphine injections. I think we have prepared a graph. This is from a real life case with a potential use of apomorphine injections. And again, this is what is called the physician tool. This is what the doctor will see on his computer. And let's focus on on the lower graph, which shows nicely the fluctuations. Just to remind that the positive values indicate off, and values around the zero line, they are on. So we see various fluctuations and at least 2 off periods in the morning hours, and in the afternoon and evening after 4 o'clock, more or less he's off most of the time. So in that case, if the doctor for any reason does not want to change levodopa or whatever, he asks the patient to do 5 apomorphine injections in the times that we see here with the dotted lines, just before the off time was happening. And so the patient would start this kind of treatment with apomorphine injections, and after a couple of weeks with this, he may be asked to wear the PD monitor again and see if this made any change. So how would you comment on that? Let's start with Angelo.
Well, I think this is a very nice example on how you could use acute treatment to correct off periods. And this is applying not only to subcutaneous apomorphine, I think, but also maybe if we will have inhaled levodopa, or like in the US, or if you could have maybe sublingual apomorphine. So anything which is administered acutely will be nice to show the benefit in terms of mobility. So as I think image is really great. I think it is a fantastic proof that you can provide something which is almost impossible to accomplish in clinical trials as well, I must say, because the clinical studies of these acute medications are all considering a reduction in off time. This is maybe minimal in total, but if you look at the plot, you will see immediately that the change in the motor condition of the patient. So I think it is possible to identify the periods when this drugs have to be administered, and also the effect that these drugs, acute drugs, apomorphine, but again, maybe inhaled or soluble levodopa have on mobility. I think will be a tremendous advantage for the patient in terms of gaining a good clinical state.
Right. Yes. Thank you, Angelo. Heinz, any comments on that based on this diagram, which is a real-life patient here?
Well, what's nice here is that the apomorphine, at least that's the attitude of the treating physician probably, is applied before the problem comes in.
Right.
So you may not only improve, but maybe you can even prohibit a major problem by early enough application of this apomorphine injection. So I think for such issues, it's quite nice. And also next day when we control, we can certainly see how effective the measurement was, whether you would need more or less apomorphine, etc. So even dosing would be something you could improve by getting an objective measurement. So it's a really interesting tool here for that reason also.
Yes. Per, any comments or?
Yeah, I think I agree with my colleagues. I think that we all know that apomorphine injections are very much underused, a very effective therapy, but it's underused. And I think again, that depends on that doctors are not quite sure of when it should be used. And I think that would be a major thing here, that you can recognize a situation where this type of therapy is suitable. That is when the patient has repeated off periods in spite of optimized therapy, but not too complicated fluctuations, not too much dyskinesias, for example, then it's too difficult to use. But identify the right patient with repeated off periods. And then, of course, it should be an active patient who understands his symptomatology and so on. But the objective monitoring could help you here to see who is suitable.
Right. So you see, we satisfy the 4 P's of mobile health: preventive, proactive, as we said, participatory, because the patient can see this graph as well. And I have to remind you that you can see dyskinesia on the same diagram with the negative values. So at the same time, you have an indication of off severity and about the dyskinesia existence or not. So it gives you the choice to do a lot of things. Right. So I think overall we are very close to end this. If you, of course, if you have any comments, you can speak up. But I think I have 2 last questions. I think it is interesting. Let's start with Per. I don't know, Per, if it has been your experience to have this fully adhering patient with the devoted caregivers who follows exactly your advice every day. He fills in his diaries, the questionnaires during the various stages of the disease. And so he is able to give you very good feedback, and you can communicate with him because you feel that you speak the same language. You know, when you say dyskinesia, you're pretty sure that he means dyskinesia. So I think these patients are very successfully treated and managed because they give us such good information. And I think, what is your experience? Do those patients really have a better long-term management than those patients that you cannot communicate very well with them?
Yes, certainly. That's the dream patient for every doctor. And I think we see that also we have a Swedish Parkinson patient registry where the patient can enter information about, for example, non-motor questionnaire, about hospital anxiety depression scale and PDSS sleep scale and so on. And patients who are collaborating in that way and give you very much information, they also will certainly get a better result of the treatment. And I think those are also the patients who would love to use a system like this, objective monitoring, and that will help them to get even better treatment. But I think we should not limit the use of objective monitoring to those patients. We should try to use it broadly also in patients who cannot communicate so well themselves how they are doing, because they might be even more helped with a system of this type.
That's right. And also by visualizing the problem, Heinz, what do you think? I think this is also motivational, and for the patient, it empowers them to see actually what happens, and when there is a change, they can also see the change. So this will empower them and make them really participate in really decision making.
Yeah, I completely agree with you. I do have some patients who are doing drawings, and such as the device is giving us in an objective manner. And for such patients, for instance, it would be extremely impressive that this equipment is even more precise than and then they can compare. And I think for adherence, it would be, and it is, a very, very useful tool.
Right, and perhaps finish with you, Heinz, with, I don't know, this is not a question, but perhaps a comment overall regarding the management of patients with Parkinson's disease and the use of objective measurement like PD monitor. Of course, obviously, time and real life practice will tell. However, trying to anticipate the future, do you think that we can prolong every stage of the disease and sustain ongoing treatment in time, or fine-tuning it, and therefore with this help we can keep the therapeutic window open for more time, offering more time with good quality of life for our patients with this help of objective measurements now?
Yes, I'm very convinced of that this would be the case, because we have done a PET study, and in this study we could show that if you optimize your treatment, this overproduction of dopamine is decreased in the brain. And to me, this is a kind of neuroprotection. So I would assume that if we keep the overproduction of the remaining dopaminergic neurons a little bit lower, and getting more help from the outside to the brain, this would be an optimization of our treatment. And to do that right, I think this monitoring system that we are discussing here is really a very sophisticated tool. So my guess and my hope would be that you are right, Spiro.
Okay, thank you. Thank you, Heinz. So I think with this, we concluded also the third part of this webinar. I think I will close this webinar, which actually happened these conference-less times and socially distancing times. So I would like to thank you, our participants, Per Odin and Heinz Reichmann and Angelo Antonini. Thank you very much for sharing your views on this topic and how the whole landscape could be changing, catalyzed, I think, by this pandemic situation. And thank you very much for your kind participation in this webinar, and a big thank you to everyone who has potentially and patiently watched it.